Black Nurses Association Population Health Committee, and our committee is on prison and the homeless population. That is our focus today. And with our focus today, we would like to talk about the health harms of the incarcerated. Last week, our focus, we talked about the different things that happen with the incarceration. We talked about reentry and prison reform. But today, we're more concerned about how are the prisoners being treated? What type of care are these prisoners getting? Are they being treated fairly? And those are some of the questions that we will definitely touch on today. I want to introduce our panelists. We have with us Dr. Pierre Brodnicks. Dr. Pierre Brodnicks is of the Greater Washington chapter of NBNA. She has been a member for over 40 years. She has 40 years of experience as a professional nurse, working, mentoring, and working with the vulnerable population. She is a recognized leader in her own right. She speaks to all different types of citizens. She does research projects locally as well as nationally. And she does a lot of work with breast cancer, the experiences of minority women. Under her leadership, she assumed leadership roles as health policy advocate through participation in many health policy councils, professional organizations, and national initiatives. She was recognized in 2013 as the Black Nurse of the Year by the Black Nurses Association of Greater Washington, D.C. And we just want to say thank you for Dr. Brodnicks for being a committee member of our organization, Health Policy, dealing with prisons and the homeless population. We have another panelist, and that would be Dr. Joan Smith. Dr. Joan Smith has over 15 years in the nursing profession. She is a nurse practitioner in pre-anesthesia nursing. She likes to think of nursing as something as making sure patients has the best outcomes possible. She's passionate about disease prevention and health promotion. She's a fierce advocate for the underserved and vulnerable population. And I must admit, the three of us, that's something that we are all very passionate about, the vulnerable and underserved population. She was recognized as an equity champion by the Satcher Learning Institute at Morehouse Medical School. And today we have an esteemed speaker who is a director of nursing, believe it or not, a former director of nursing. And this is Dr. Mcintosh, a native of Selma, Alabama. She's been a registered nurse in the state of New Jersey for more than 38 years. She worked at the University of Medicine and Dentistry for 10 years as a nurse manager in ambulatory department. Dr. Mcintosh was employed at the County of Houston Department of Corrections for the last 14 years. She also became the first African-American director of nursing in the medical department at the Hudson County Correction. Dr. Mcintosh started her own business in 1990, Professional Education Association Corporation, where she taught many nursing students and still does. She's also is a very active member of the Community Emergency Response Team, and she's also a clergy as well. Dr. Mcintosh has a very colorful bio that is already listed, and I would love for you guys to be able to read her entire bio because she's done so much. She received her provisional board certified chaplain certification from Spiritual Care Association, and she's also a certified correctional health professional. So I want to say thank you for our guests, panelists, for being with us today. And we want to start it off with a little bit of statistical data for none other than Dr. Joan Smith.
Did you know that Medicaid will not pay for inmates' medical care while they're in prison or jail? And in some states, inmates actually have a copay, which may present as a barrier to them getting access to health care. People in prisons and jails are disproportionately likely to have chronic health problems as well as substance use and mental health problems. In some cases, they may be navigating prison life with disabilities or even pregnancy. According to the Bureau of Justice of Statistics Survey of Prison Inmates 2016 and Centers for Disease Control and Prevention, people in state prisons suffer disproportionately from various medical conditions compared to the overall U.S. population. So, for example, people in state prisons have much higher rates of illness compared to the general public. 1 in 10 people in state prison has been diagnosed with hepatitis C at some point, which is more than 5 times the estimated rate of U.S. adults with the viral infection. Treatment for hepatitis C has a high cure rate, yet 80% of people in state prison who have ever been diagnosed with hepatitis C still have it. Rates of several chronic conditions such as diabetes, asthma, hypertension, and other forms of hepatitis have increased in state prison. More than half of people in state prison had some indication of mental health problem, yet only about 1/4 of the total population have received professional help for their mental health since entering prison.
Right now, but basically she's talking about the statistical data as it relates to the incarcerated. She's talking about the fact that a lot of incarcerated individuals, believe it or not, they don't have health insurance or co-pays or anything like that taken care of. She's also speaking about the incarcerated individual, and I can't wait to hear Dr. Mcintosh address some of those questions. She's also addressing the concerns of incarcerated women and what happened to women when they're giving birth. So she's giving a little bit of statistical and data of what happens with those individuals. And we want to go ahead and get started. And we want to get started with our speaker, Dr. Mcintosh. My first question for you, Dr. Mcintosh, would be, could you tell us what type of programs are in place in the prison for inmates that are newly diagnosed with hypertension, diabetes, and HIV?
Good afternoon, and thank you very much, Dr. Neal, for inviting me at your webinar. It's a pleasure. And what are some of the things in the program that placed in a prison of prisoners pertaining to hypertension, diabetes, renal failure, and HIV?
Yes.
What the setting that we have in corrections are what we call chronic care clinics, and they're done Monday through Friday. On Monday, we usually have the chronic care clinic. It will start with hypertension. We have a nurse and a doctor assigned to that clinic. Every client who has hypertension name will be put on that list. They will be called down between the hours of 9 a.m. to 1 p.m. on every Monday of the week. On Tuesday, the clients who has been diagnosed as being diabetics or diabetes, their chronic care clinic is also on Tuesday. Renal clinic is usually on Wednesday. We have a wound care clinic on Thursday, and then we have HIV clinic. So each clinic is assigned a nurse and a doctor to take care of the clients.
I like that. Do you guys have educational programs in place for people who are newly diagnosed with renal failure or diabetes? I mean, do you give them educational classes, or how do you handle that in a prison setting?
Usually the nurses who has the chronic care clinic would do the educational piece, and they also would pass out educational materials. And it's also would be reinforced by the physician, whether it's a medical doctor or nurse practitioner.
Oh, that's awesome. Could you talk to us about the biggest challenge in meeting the needs of the patients when it comes to mental health and substance use disorder? Because they talk about substance use disorder in the prison. I mean, somehow they have ways of getting it in. So how do you guys deal with that in a prison setting?
Well, usually when an inmate comes in, a client, we don't use the word inmates anymore. We use the word client or patient. Usually when the client comes in, they come in through our intake room and they see a nurse. This is where we actually see an overall or a view of that patient. and we do a history assessment. So if they have any type or on any type of medication, for example, for mental health, if they was on any type of medication, what we would do, we get all the list of the medications, and then we would confirm it with the pharmacy if they had gone or purchased their medication through the pharmacy department. Once they're done that, immediately that person is assigned to a nurse, and that nurse will follow that person. But however, what we find out with the mental health clients, they don't want to take the medication.
Oh.
They hoard the medication, they cheat the medications. And that's one of the things that the nurses are known to. When you give a client the medication, they have to make sure they open the mouth, make sure they swallow the medication, because they're easily known to cheat. They'll swallow and put the pill underneath the tongue on right underside of the gum so you can't see it. So those are some of the challenges we find with mental health. As for substance abuse, they want, when they see the doctor may order the medication, and when the nurses goes out to the tier to give them their medication, they claim that the doctor has increased the dosage. Actual reality, they're not, because they want to get more. Once they double the medication, they give that good feeling of getting high. Mm-hmm. So they will actually try to trick the nurse to give them more medication, extra medications, and all, but those are the challenges we have with the mental health department and mental health patients and the substance abuse. They want more drugs for substance abuse so they can feel good or get high. And the ones that are mentally ill, they don't want to take the medications. And then you find out why they're out here in the community, they don't take anything. But when they come to the jail, all of a sudden, I want my medication, I want this, I haven't had my medication. And when you call the pharmacy department, they find out they haven't filled the prescription almost 6 months to a year. So those are some of the challenges we have. So we really just don't take their word when they come in with a type of medication. We confirm it with the pharmacy or call the physician.
I have a question. What is the, we have a question in the chat box. The question is, what is the level of this particular facility? Is it a state? Is it a federal? What type of prison?
It's a county jail. It's a county jail.
Okay. And with, okay, I see what you're saying. It's a county jail. Okay, because I'm sure that
Dr. Neal?
Yes.
This is Dr. Broadnax.
Yeah.
I was the administrator over the Department of Corrections for the Washington, D.C. And we were responsible for the jail or detention center, the prison, as well as the correctional treatment facility, which was an infirmary. So we had an entire system within the District of Columbia, which has since been dismantled, except for the detention center, which is known as a jail, and the treatment facility. And the other patients, well, actually the persons who are incarcerated are transferred to the federal system. I hope that clarifies your answer.
Yes, it does. Well, I have a follow-up question. Let's talk about teenagers. How are they treated different, teenagers in prison, when it comes to health care? And this question would be for both of you guys. And I'll start with you, Dr. Broadnax. Do you feel that the teenagers, they get better care in prison because maybe they didn't have health care outside of prison? What have you noticed?
Exactly. Teenagers who are coming to the criminal justice system, they have not been, usually, this is a broad generalization, they have not been privy to the preventive care or regular checkups, even though they need immunizations to attend school in the District of Columbia, and there are other requirements, because you need parental oversight and guidance. Sometimes they don't get it as closely as we would want young teenagers to have. And so they may not get the proper follow-up and treatment that would be expected on the outside. So they tend to get better, stricter care as needed when they are incarcerated or coming to the criminal justice system.
Okay, Dr. Mcintosh, could you answer that same question? How are they handling that in New Jersey?
In New Jersey, in my setting, we had what we called Juvenile Detention Center. And the juvenile detention center is usually, most of the clients are arrested from the street, brought into the police department, and then they're brought to the juvenile detention center. Again, it's almost similar to setup. We do the intake on them, get a history, the medication, or whatever they're complaining at that time. And we cannot administer anything until we get permission from the parents, parental approval. Say if there's someone who's diabetic and they're on insulin, or they may be on a PO pill, we cannot administer anything until we contact that mom. And then we will call again the pharmacy department and call the doctor to confirm the medication, whatever treatment, whether it's psych, mental, med-surg issues, we have to confirm that. But as for the children, I think they get better care. Because once they come in, they can go to school. We do have educational programs for them to go to school to get your GED. They also, they play games, they play basketball, they get 3 meals a day, breakfast, lunch, dinner, and a snack at night. The only thing different when you're talking about treating them medically is that the dosage are much smaller than we would do for an adults, but they get a lot of attention when they come into detention. And I find out it's like a revolving door. They may get discharged this month, 6 months when they get cold, they do something to come back into the facility again, November, December for the winter. They're allowed to play game, basketball. They go out, they watch TV as long as they want to. So they have a lot of privileges compared to, I would say, the adults facility.
That's amazing that they use it as a revolving door. They go out, they do something. So just so that they can come back again, is it kind of like hanging with a club? They want to be with the same people again?
Yes.
Or is it that you guys are giving such amazing care? What do you think?
Yes, they do get amazing care. And not only that, what I would say is that sometimes you really can get close to them, attached to them. Okay. And another thing that you find out most of the time, it depends on the situation and the crime, that the parents don't want them to come back home. So those are when you will see the revolving doors that comes in and out, because once they hit the street, where they're going to go, they may stay with a friend for a night or two, but going into weeks and weeks and weeks, they just out there. So that's what we call the revolvers, the revolving clients that comes in and out when you talk about juvenile detention.
And it's really sad when they go home and, like you said, the parents may not want them back,
right.
And they have nowhere else to go. So like you said, when it gets cold, they come back,
Right.
Which is sad. Yes, Dr.
We say the way Dr. Mcintosh described it is accurate, but we also look at the other side. The teenagers have been so disruptive to the home.
Yes.
And they usually have younger siblings that parents would have to weigh the safety of the home and the younger siblings against this one teenager who is at this point incorruptible. I mean, they cannot manage them in the household.
Mm-hmm.
So they know they don't want to go to a shelter. The streets are harsh. And again, they're teenagers, and they're predators who prey on these teenagers. And so you will see a revolving door in and out, because as much as we don't want to acknowledge it, the jail and the correctional centers are safer maybe than the streets.
Speaking about jails and correctional facilities being safer, let's talk about prison overcrowding. With the overcrowding of prison and jails, how is isolation handled for inmates requiring isolation for certain types of medical conditions? Or let's say you are severely immunocompromised. How are you guys dealing with that? And I'll go with Dr. Mcintosh with that question.
I'll mute myself. When you're talking about crowding or overpopulation of the clients, if someone who has, just say that they sickle cell anemia and they're in crisis. So what we would do, we would bring that client to our infirmary, whereas he's close to the medical department. There are single units. He will, the nurses will make sure he get his medication. Any other, even if you someone that comes in that says real sick and they've been arrested, got beat up, maybe have a fractured arm or fractured leg. Once the nurse does assessment, they will call the charge nurse and tell the charge nurse to have the doctor come evaluate the patient, and that patient will goes right into our infirmary immediately because he needs immediately attention. We also find the situation with the clients who come in that's on opiates, cocaine, that's really strong out and high, that they will also be admitted into our infirmary because they need to be watched and monitored closely. As for the crowded population, we sometimes, the cells may hold 3 bunk beds. You may have to end up adding another mattress on the floor, which is really overcrowded. And you mainly find that in the male population, more so in the female population. So they are evaluated immediately when they come in, so we'll know where to place each person that comes in.
Okay, thank you. So my next question, I want to change it up a little bit. And I want to talk about, how do you give culturally competent care to a transgender inmates? Because we're in 2022 and we're in a whole different era. How do you deal with that, Dr. Mcintosh? How do you give culturally competent care to a transgender inmate?
Well, with a transgender, what we do, we have a special units just for those type of people. And they're not treated differently than anyone else, okay? If the person say I'm a she, we treat them as a she. If they say I'm a her, we treat them as a her, or him, or we, she, her, whatever. we just don't get into it. If they want to talk about it, we listen. We do not try to differentiate their way of living, their belief, or their culture. So that's pretty much why we handle that situation. If they need special medications, we have to make sure that we maintain the medication. You have to realize when you're talking about a person, whatever the way they live in the outside in the community, they still live the same way when they're incarcerated. We do not deviate from the medications, the treatments, or anything. So we have to recognize that person to who she is.
That's true. That's true. Dr.
At the time when I was the administrator,
Mm-hmm.
that was not an issue in the media such that it is now.
Mhm.
And as Dr. Mcintosh had said, the same way they live on the outside is what we maintain in correctional healthcare. And the main issue is the nurses who bring their biases into this healthcare setting. And so we have to make sure that as professional nurses, that we emphasize that we cannot provide care that is biased, or that you cannot treat a patient based on how you feel, but we're treating whatever is occurring at that time with that patient.
Thank
so
you.
Our role is not to be judgmental.
That's true. We have a question from the chat box, and the question is, there is some research that indicates that juvenile females are at risk of sexual, physical, and emotional abuse by fellow inmates and even staff. Would Dr. Smith and Dr. Broadnex speak to that? Well, Dr. Broadnex and Dr. Mcintosh, would both of you guys please speak to that?
In some settings, there are predators in such that the inmates and the staff. So people who are viewed as weaker are subjects of abuse. And you have to step in when you see abuse and intervene. So it would not be different in incarcerated settings, any different than it would on the outside. But we cannot allow it if we see it.
Thank you. Dr. Mcintosh, same question.
Yes, in juvenile detention, usually what we did at that time, we had female officers to take care of the female inmates. and the male took care of the male inmates. There were times that maybe you see the little boys want to run over, hug, and kiss the girls, but immediately we had cameras throughout the whole entire facility, and we had one person to monitor the facility. And once that is seen, they report it to the captain who were in charge to make sure it doesn't happen again. But in the adult facility, it has been known that I did have one experience where an officer did have an affair with one of the female inmates. So it does happen. How it happens, I don't know, but it does exist.
Wow. So Dr. Bruness, that brings me to, I know you're in academia. What do you suggest, or what approach should we take to include nursing care of the incarcerated in the nursing curriculum for our students? Because some of our nursing students will end up working in a prison setting or a jail setting. So what are your ideas on that?
The number one recommendation I have is that the content should be presented by someone with expertise in that area who is culturally sensitive and societally sensitive to what it means to provide care to persons, to incarcerated persons. We have people in the population, when I say population, people in society who do not believe that incarcerated persons are deserving of quality care. In one setting in which I was working, the system was under court order to provide care within 24 hours of request. This was a major point of conflict because people on the outside would say, well, I'm not entitled. I can't get an appointment with my doctor. Why should they receive a higher level of care? But because they are incarcerated, we are responsible for their quality of care. So when you are introducing the topic to students, you have to have the appropriate faculty member introducing the topic. And usually this type of clinical rotation should be provided first in a outpatient setting. No, I'm sorry, outpatient, lower security level, sort of like at a halfway house, and then they should go to actually a jail or a prison setting to observe what is actually occurring. And when you have compassionate administrators like Dr. Mcintosh, you find that the quality of care is much higher. But students must be introduced to the topic of healthcare in correctional settings, because the correctional setting is actually a reflection of what is occurring in the outside environment.
Thank you. So Dr. Mcintosh, nurses or anyone working in your setting, I know we have to have CEUs. Do they have to have a certain amount, different types of training or different classes or workshop or something before they actually will accept that job? How do you do the orientation process from regular nurse working in a hospital to a nurse working in this setting?
Usually what I do when I would go and visit hospitals, when they have like educational day, sometimes I'll be the guest speaker and introduce what the jail is all about. And I would actually tell them, I'm looking for someone who is a registered nurse, at least has a bachelor's degree, a master's degree, at least 3 to 4 years of experience in med-surg, because that's mainly what we deal with when we deal with crisis and trauma in the jail. I also explain to them, I'm looking for someone who is open when it comes to cultural, because we have different type of culture. We have different type of religion. You have to be, and you're gonna hear all kind of profanity. You're gonna have to just open up and listen majority of the time, whatever the clients say. You can't be harsh with them, talk negative to them, curse them out. They may curse you, but you have to be professional. I'm looking for someone who's going to be professional to come in and work with me. And usually what we do when they come in, we send them to training. We send them to 4 classes. One of them is, it talks about do not share your personal information with the inmates. Don't tell them about your telephone. Don't give them your telephone number. Don't tell them about your family members. I go through all the do's and don'ts. We also had ICE, immigration custody, where we send most people back to the country, whether they're from India, Africa, whatever. We have a whole class on that for 2 days. Wow. We do that yearly because those are one of the requirements in order to meet our accreditation. I also send them to mental health for 1 week. I send them over there, let them know what the mental health department does. I have them work with the nurse practitioner. So when they come in and I hire them, I at least give them 2 weeks of training. So they have a general idea of what they're going to do once they come into the facility. I'll let them know that some days are going to be short of staff because there's a shortage. There may be days you may be mandated to work overtime. Okay, so I'd be honest with them up front. If you cannot deal with these different varieties things as being a nurse, this is not the field for you to work in. And that's pretty much what I emphasize on that when I talk and do my lecture to people when I go out trying to recruit nurses to come into correctional.
I think that's very well. I think that's good because, I mean, with every 2 years with our license, we have to get CEUs, and they should have a whole set of CEUs just for this particular type of nursing. I mean, we have it for mental health and other types of nursing, so why not? So I think that's very good. Yeah. My next question goes back to Dr. Brodnick's. I want to go back to the transgender. How do you think we could include transgender nursing care in the nursing curriculum? Because as nursing students today, as Dr. Mcintosh said, we will refer to them as a he, she, or however they would like to be, however they want to be recognized as. Do you see this as something that we should be teaching in nursing programs as well, so that when these new graduate nursing goes out into the profession, that they are familiar with the transgender population and how to care for them?
How the issue of transgender and sexual orientation is taught in the curriculum, it actually is no different specific to transgenderism for correctional patients. What you're teaching is compassion. Compassion for a person who has a health challenge that you must address. Our chapter had a workshop on care or healthcare needs of transgender patients. Well, actually in the LGBTQ plus community. And it was a few years ago, but it was an eye-opening experience in that we really had to own up to and face the challenges that they were facing in trying to access healthcare. And this was on the outside. So on the inside, when I say inside, when they are incarcerated, it is similar to what they face on the outside. Those who don't understand transgender healthcare needs, those who don't want to provide that care based on what they will say is their religious basis. Not that I'm disputing that, but as professional nurses, we are there to care for the health challenge, whomever the patient happens to be who is presenting to us. If they have hypertension, if they have sickle cell, if they develop breast cancer, we're there to treat the patient and not pass judgment on any other issue.
So basically you're saying we should teach the students to have these sensitivities intact so that they can treat people with respect, compassion, dignity, treat everyone across the board the same, regardless if they're transgender, if they are an inmate, if they have a disability, if they have a different religion or whatever. You should treat everybody the same.
It is actually the ethics of care, because we are being ethical care providers.
Yes, that's true. So I have a question, and the question is from the chat box. And this is a topic that we will be covering next week. Our topic next week will be incarceration. Where are our sisters, mothers, and daughters? And the question is, do facilities have special care for pregnant incarcerated women? Is the stress of giving up their newborn to caregivers other than themselves evident? And how is this post-delivery issue dealt with by incarcerated care? And I'm going to give that question to Dr. Mcintosh, because you probably actually have experienced that. We will talk about this at length on September 14th. So the person who brought up this question, please make sure and join us next week, Wednesday as well. But can any one of you guys address that briefly?
Yes, we have experienced, I think it was like 3 incarcerated women who were pregnant, and one was on methadone. So again, you had to treat her like you treat the people on the outside, and we treat them inside the jail, and we had to continue them on methadone. We do not discontinue medication when a female woman is pregnant. We had to continue to do that, and what we had to do was make an arrangement for her to go out and get her methadone according to what she was getting doing outside. Usually, we have an OBGYN doctor that comes in on Thursday evenings, and he would see her, he would assess her. As she get closer to her due date for her delivery, we will actually send that client to the hospital for delivery. We do not deliver any babies in our facility at all, but they make sure that they get the vitamins, whatever care is required, according to treat that pregnant client, she will be treated. And once the baby's born, usually she will ask a family member to take care of that child, and that child will be passed over and signed to the grandmother, mother, whomever it may be, until she is discharged from this service. So that's the way it's done in my facility.
So I guess her next question was, is it evidence the stress or that puts on the individual that you had the baby and now you have to basically give the baby away?
Well, the baby's given away, like I said, mainly to her relatives until she's discharged from jail. I mean, those are 2 I had, the 3 women that I had. The baby was born, the father took the baby. Once the baby was born, he was there to pick up the baby on the discharge. The other 2 young ladies, they asked their mother to take care of their kid until they were discharged. So those were the 3 experiences that I've had in my facility.
Okay, that's pretty good. I think that's good that they were able to at least give the baby to family. It was just a temporary situation. I hope that answered Ms. Claudia's question. My next question, to kind of pivot a little bit, is pretty much about organ donation. With when patients are incorporated, and I'm calling them patients because Dr. Mcintosh, you said that we do not address them as inmates. So we address them as patients. And I know that we have patients who die in the prison system. How do they handle organ donation? Do they have a choice, or do they automatically take their organ? How is that handled? Dr. Mcintosh.
Well, I never had an individual for donation, so I really can't answer that. I don't know if Dr. Bronak have experienced that in your facility.
At that time, they were handled the same way. You know, they are screened for appropriateness, make sure they're clear of transmissible or communicable diseases. And if they had provided and planned for organ donations and they fit the criteria, when they are dying, they are transferred to a hospital. You know,
Okay,
but they have to meet specific criteria. You know, it's not because they are incarcerated that their organs are automatically taken. You know, just like incarcerated persons cannot be forced into research studies, they have to be willing participants and they cannot be enticed. It's the same way with organ transplants. They cannot be induced or offered any kind of incentive to be organ donors. So same criteria as on the outside.
thank you. I guess my next question would be about unfair treatment by physicians. Dr. Mcintosh, have you noticed where the physicians would go that extra mile to save a life, or maybe did not give the same stellar treatment of care as they would for someone on the outside?
No, I have really have not experienced anything with any of my physicians because we go extra miles for all of our clients. Even if someone have, we want to say that, try to hang themselves, okay? And we cut them down and we still revive them. No one in our jail is known to die. Nobody dies in my jail. We would do CPR until the ambulance come and get them. So like I said, we go extra miles, try to make sure that our clients get the treatments they need. We do have backup pharmacies if we don't have the medications in our pharmacy area in the facility. Not only that, if they need a certain medication that the clients are taking outside and it's going to take our pharmacy department, sometimes take 2 to 3 days to deliver it, the doctor will actually call the pharmacist and have one of the officers pick it up so that client can maintain his health care. So I have not seen anyone that really didn't want to take care of any of the clients and also apply to the nurses.
That's perfect. My next question is from the chat box. It's a very good question. How are cardiac emergencies handled? Is there a delay in care allowing first responders access to the facilities? Dr. Mcintosh.
The cardiac care emergencies is handled immediately. Anything that goes on that needs attention immediately, usually they are brought to our medical department. In our medical department, we have an examination room. And usually there's a doctor there, a nurse practitioner, nurses there. So anytime, even if we have a code, the nurses goes out of code, they bring that patient back into the examination room and it's handled immediately. If someone who needs to go out to the hospital, the nurse or the doctor will call that contact emergency department and let them know that we're sending someone out. If the ambulance needs to come in, the office is notified at the gate to let them come in. There's not one time that they have any difficulties in getting into the facility.
Oh, that's beautiful. Dr. Broadnex, could you, same question?
Yes, I actually concur with Dr. Mcintosh. Because in our prison system, the prison was located 22 miles from the actual jail site. So when there was a trauma or cardiac emergency, the team was called and the infirmary actually stabilized the patient because the infirmary had a physician on at all time who was trained in emergency resuscitation. And it was usually time enough for the advanced life support team to arrive and transport the patient to a trauma center in case of a trauma. And in cardiac emergencies, the team on site could actually stabilize the patient. So no delays occurred, whether it was a cardiac event or whether it was a trauma event.
That's good. Now, we have a Miss Reed on the chat box. She says, if anything, they often receive treatment they exceed community standards. And everything you guys are saying is true. For example, a few minutes ago, we were talking about the pregnant, incarcerated pregnant women and the stress that they go through. And one of the things I really like what you said, Dr. Mcintosh, yes, we make sure they get the prenatal care. We get they make sure everything is taken care of. And when it's time for them to have that baby, we send them out. We send them to the hospital.
Amen. Amen.
You want to
And-
get them out of there way before they even deliver that baby. Probably the minute they start going into labor pains, you're
Yes.
sending them out of there.
The water
And,
break, they're gone.
Ms. Reed has spoken correctly in that some of these incarcerated systems are under court orders to provide a certain level of care because of past problems with care delivery.
Mhm.
And so you will see the 24 hours for request. You will see transport to the hospital at the first signs of delivery, so that no delay will occur because the incarcerated persons are under the care of the state
Mhm.
or the federal government. So they must receive what's perceived to be a higher level of care.
well, I have a follow-up question to that. Do you guys see a difference in the care if the person was in a federal, state, or maybe a private prison? Do you think the level of care is different if they are in a private prison as opposed to a state or federal? Who would like to address that question first, Dr. Broadnix or Dr. Mcintosh?
Well, I've had experience with all three.
Mhm.
The private prisons are held to the same standard as that state.
Mhm.
And the experience has been that the federal government has the highest standards
Okay.
in terms of programs, educational programs, recreation programs, rehabilitation programs. And again, the state's system is predicated on the budget.
Yes.
So you may see a different level when compared to the federal government. But as we all know, everything is driven by by budget, but they must meet standards. They must meet standards of care. They can't go below that.
Thank you. Dr. Mcintosh, did you want to add anything to that?
Well, like I said, mainly my medical department, we treat everyone fair and equally. According to the diagnosis, the treatment, we are ACA accredited, and we have to meet those standards, whether you're rich, poor, whatever level you may be when you come in. We have had doctors and lawyers that have been admitted for different charges, and we didn't treat them any better than the ones who didn't have $0. So our standards care is the same across the board.
Thank you. I have another question from the chat box. What about hospice patients at end of life? Are family members allowed to stay with patients until the end? Dr. Mcintosh?
Well, usually with our hospice care, or the end of life, I should say, we usually keep them in infirmary. And we had a couple to actually pass in the infirmary. Sometimes if they really need medical care, we had a nursing home that we made an arrangement that we would transfer them over there for the end of life. And they would have an officer to be there at the bedside in street clothes. He wouldn't be in uniform. And they sometimes would allow the family member to come and visit, but they won't be there at the bedside until the end of life.
Thank you. What about you, Dr. Broadnix?
No, usually when a person is at end of life in the system at that time, the family member was not able to stay. They were in the infirmary also, as Dr. Mcintosh had said, but the family was not allowed to stay with the patient.
Thank you. Next question from the chat box. Are your clients screening according to the current guidelines? For an example, like the colon screening for men, breast cancer screening for women. Do women get mammograms? Are all of the screening guidelines the same in the prison system?
Yes, my OBGYN doctor would actually come in and examine and does a mammogram if required and needed. Whatever needed for that person, that female at that time, he will order that and we will carry out the orders.
Okay.
Same here.
Okay, and then the next question to the participants. Equitable care is not always the standard in some communities on city, local, and county levels, in my experience. And this came from Ms. Claudia. Ms. Claudia, would you like to speak to that? You're just making an overall statement. You're welcome to speak to that, please.
Yes, thank you. Yes, I have found that it sometimes the levels of care does not always meet the standard. And I hate to sound very negative, but my experience has shown that some incarcerated individuals who have extremely significant health issues are often only treated to the standard of addressing, but not necessarily therapeutic. Therapeutics was one of the big absences that I noted. And the other issues seem to be that, and this is really not pointing a finger at the staff again, but that some of the care is beyond even what their facilities will allow. And I'm told, the state's ability to support the additional care that's required financially.
Thank you. Thank you. And I would like Ms. Reed, she has a very good, I like her statement, standards of care are the minimum, but it depends on the budget, size, population, etc., as to what is offered. Ms. Reed, could you please speak briefly to that?
Oh, how are you, everybody? Sorry, I chimed in late. I'm Laurie Reed with the Atlanta Black Nurses. I'm also a correctional care nurse manager and a health auditor at the federal, state, and local level. I just wanted to say thank you for hosting this, but I guess I was just chiming in from the chat. I'm also out of the country, so I was hesitant about speaking. But I was just saying, you know, in terms of whether or not they're in a federal, a state, or a county level, whether in a county jail or state prison or a federal prison, it will depend. And just like I stated before, it will depend on what the sentence is, how long they're there for, what their own budget is, who is providing the health care. And basically, when you come down to privatized health care, which a lot of facilities do have privatized health care, which basically means they use a company to provide medical, dental, pharmaceutical, and psychiatric services. It just depends on what that budget can pay for, what will allow, but rest assured, everything that we find that we need to check, even if we have to send it out, get special permission, we do that as best we can. Is it a perfect system? Absolutely not. Absolutely not. We have a sick call system. We have a chronic care system. Detainees are seen, inmates are seen more often than probably most people on the outside. For example, our diabetics, they get an A1C probably every 3 months, every 3 to 6 months, depending on what's going on the outside. You might get one once a year. So it just depends on what's going on. And the psychiatric services are some of our highest needs, and we don't do very well. But unfortunately, you all may have said it. Prison systems have become a default for mental health care in a lot of cities.
Yes, it has. And I want to say thank you to both you and Ms. Claudia for those statements. And I really, really definitely want to say thank you to Dr. Mcintosh for being our guest speaker today. And at this point, I want to turn it over to Dr. Broadnex to could you wrap it up and kind of summarize everything that we discussed today? Because our next topic is going to be what happened to our mothers, our sisters, our daughters. That will be our topic for next week. But could you wrap us up for today, Dr. Broadnex?
Good afternoon, everyone, and thank you for being on the call today. And as always, Black nurses step up and step out and show that we have a wealth of experience in our midst. Thank you, Dr. Mcintosh, for being our guest speaker, and for everyone for attending this second in our series of webinars. But today our topic was on the healthcare issues of incarcerated persons. And we first started off, we have a statistical overview with Dr. Smith, but it will be available on our NBNA website, so you can get an overview of what how healthcare is impacted in the prison system. We talked about how patients access care, the types of services that are available within a prison setting. And we talked about the different levels of incarceration, from the jail to the prison, infirmary, state levels, county levels, federal levels. And so there are all different types of incarceration. And we talked about what do you do when you are faced with persons who are transgender, and the quality of care that we present. How is it being introduced to students in an academic setting? We also talked about what happens when people give birth, what happens to those who are dying, and what happens to their organs. So we covered a lot of topics, and we want to thank the members who posted in the chat and those who shared their experiences based on their questions. And I think I covered everything. A lot depends on budget, determining what is actually going to be provided, what types of services are going to be provided. So Dr. Neal, Dr. Mcintosh, did I cover the high points?
Yes,
You did.
yes, you did. Dr. Mcintosh, we normally don't do this, but is there any last thing that you would like to leave with the guests today? Is there any last thing you would like to say about the prison system, or an incarcerated patients, not inmates? Anything, last thing you would like to say?
I would just say, out of my 38 years of being a nurse, starting from staff nurse, management, and director, the years of experience really has been euphoric for me.
Okay.
And if you're looking to go into this area, you just have to make sure this is what you want, because it's going to be a challenge. It's entirely different from what you worked in the hospital, nursing home, and working in corrections. I found that, to me, it was much easier. Even though I was over all the doctors, the nurses, the medical records, the lab technicians, and pretty much work with the officers. To me, we were like work together as a group. It was more like a family. If someone got ill, someone passed, we went and supported that family and everything. But it's something new. It's something that you want to do. And I said, it's just something that you have to have love and compassion for. You have to have compassion for these people. Even though they may have committed a crime, I don't look at the crime. I never look at what they came to jail for, but I looked at what the issues were in front of me. And I made sure that my doctors and nurses took care of that issue. And that's pretty much what I want to say. It's a pleasure. Thank you for having me. Nice meeting you, Dr. Pierre Bronack, and Dr. Laura. It sounds like you're a nurse practitioner. I'm not sure, but thank you again, Dr. Neal, for having me on board. Thank you.
Thank you. And remember, next week we will be here again at 12 noon. What happened to our mother, daughter, sisters, and who are incarcerated? On the 21st, the impact of incarceration of families and the community. If you have all of our men taken away, what does that do with our children? What does that do with the family unit? If all of our women are taken away to prison, what does that do with the community? What does it do with the family? And on the 28th, we're ending this series with mass incarceration. That's how we're ending it. So please don't forget to fill out the evaluation form. Thank you very much for enjoying us, and have a great rest of your day. Goodbye, everybody. Goodbye.